Hello everyone and welcome to today's public health webinar. We've got Dr. Brett Sutton who will be presenting about disease elimination and eradication, modelling strategies and challenges.
Thank you very much. Hello outside world and fellow trainees. So you'll see I'm a public health registrar. I've been given the privilege of being able to present from the faculty, and I think that's because I'm working in the hepatitis C space at the moment, and it's a brave new world in hepatitis C, and I've done some work in elimination and eradication stuff in the past. So polio, guinea worm and hepatitis C will be my kind of case studies, my three favourite diseases in the world. So I'll talk about them just with respect to elimination and eradication strategies, how you understand them, and then approaches to getting to where you want to be, and some of the road bumps along the way. So I'll go through some definitions, and then the case studies in eradication are polio and guinea worm, and then a case study in elimination is Hep C virus, where I'll talk through how we got to understand what the problem was, some of the elements of network and modelling, the 4 pillars for elimination, the Australian context, and the new drugs and how that's really been a game changer, and then the challenges in the Hep C space and maybe some lessons for other diseases. So eradication and elimination have some specific definitions associated with them. Eradication is the knock 'em dead. So the complete and permanent worldwide reduction to 0 of new cases of a disease through deliberate efforts. We've only got one human example, so that's smallpox, where it's gone from the world and interventions are no longer required to keep it gone from the world. It's held in 2 laboratories in Russia and the US. But there is no human transmission, there is no more disease in the world from smallpox. There's an animal example of rinderpest, which is like cow measles, and rinderpest has also been eradicated from the world. So through vaccination efforts, it's gone the way of smallpox. But they're the only 2 organisms that we have examples of eradication. Elimination, on the other hand, is a reduction to 0 or very low defined target rate of new cases in a defined geographical area, or sometimes worldwide. But you need ongoing interventions required to stop it coming back with a vengeance. And what makes something a target for elimination rather than eradication, for example, that it has an environmental niche. So tetanus, which exists in soil around the world, can't be eradicated. We can only aim to have everyone immunised to the point where human cases are very, very few in number. So what do we need for eradication for a start? What are the key requirements? Firstly, there has to be some epidemiological vulnerability about it. You need to be able to diagnose the cases, for example, so that you can know what you're dealing with, and you can be sure about the progress and the case numbers and the disappearance of it. Natural immunity or vaccine-induced immunity needs to be another feature as proof of concept that you can protect people and thereby being on the path to eradication. There also need to be effective and practical interventions. So it's not always a vaccine, but it might be cure to stop transmission, or it might be vector control, or some other break in the transmission chain, and guinea worm's an example of that, which I'll talk about shortly. And then it's generally said that there needs to be some demonstrated feasibility, because it's all very well on paper, but it helps if there's been some local eradication in a country, in a region, on an island or whatever else, and that there's no zoonotic reservoir. When there's a zoonotic reservoir, it's a little bit like an environmental niche. It can come bouncing back if you can't rid it from that zoonotic reservoir as well. But there are a number of other considerations, the cost and cost effectiveness as to whether you're going to have a go at eradication in the first place. smallpox is the poster child of eradication in the sense that the total cost has been repaid every 27 days ever since it was eradicated. So, you know, it was enormously cost effective, having killed 2 million people a year historically. To have no human cases now, it's shown its cost effectiveness enormously. So you need to consider that. You need to consider the burden of disease, which is a related thing. Is it severe enough as a disease? Does it have the human, social and healthcare costs that make it a worthy target? And then political and cultural considerations. You know, hepatitis C is fraught with the issue of being primarily in intravenous drug users or people who inject drugs, and therefore doesn't always get the community or political impetus behind it. We're very fortunate in Australia. Anyway, I'll get to that. And then cultural considerations around whether you think you can overcome some of the behavioural impediments that might be there in terms of stopping transmission chains. So what are some of the diseases that have been spoken of with respect to eradication? Guinea worm, which I'll talk about, and poliomyelitis, top of that list. Guinea worm, dracunculitis, poliomyelitis. Mumps has been talked about. I'm not sure it should be on this list. I think the more we learn about mumps, the more challenging we understand it to be with respect to eradication, but it has been eradicated from Finland, I believe, but they did it with very high 2-dose immunisation coverage, which, you know, may be not feasible for a global eradication. Rubella, on the other hand, has been eradicated from the Americas, North and South America, or the PAHO region of, as WHO define it, and all through immunisation and obviously case finding. So rubella is a genuine eradication target, as is lymphatic filariasis, which is maybe more commonly known as elephantiasis. It's been targeted for eradication by 2020, and there are a number of countries that have already stopped treatments for it because the eradication program involves annual mass drug administration, and there are a number of countries that have now stopped that and are just surveilling for new cases and not seeing them. So proof of concept has already happened with filariasis, and it is on target as a global eradication strategy. Cysticercosis, or pork tapeworm, another one that is probably looks better on paper than in the real world, but it should be feasible to eradicate it either through basically you know, the separation of human faeces from pigs and vice versa, for that matter, because it's in humans and pigs as hosts, and if you can stop the cycle of ingestion between pigs and humans, then you can basically stop it. That's what's happened in developed countries, and that's what could conceivably happen in developing countries. There's also vaccine for pigs that's under development, and there are some treatments that can be given to pigs and people that can, in theory, reduce the burden, but it's a pretty tricky one for eradication. Measles is definitely on the radar. We all know measles is the most infectious virus out there, so it's a challenge in terms of the levels of immunisation coverage that you need for it to be truly eradicated. But if any place is proof, then Australia is a country. So it was declared eradicated in terms of endemic transmission in Australia in 2012. And if you can get to 95% coverage or thereabouts globally, then measles is a feasible eradication target. But, you know, it continues to persist in England. It's never ceased endemic transmission of wild measles virus. So, you know, even in a well-resourced, well-educated country, it can, you know, persist and become a real challenge for eradication. And in large part, you know, the UK has suffered from Andrew Wakefield's spurious paper, and the the connection between autism and MMR. So there were a number of places that are still trying to catch up with appropriate vaccine coverage in the UK. And then yours, not mine, a cousin of syphilis. It causes skin, bone and other lesions, but it's entirely curable with penicillin, and is also a target for eradication. Also, WHO have declared 2020 as a deadline for its eradication. So it's definitely a feasible one. So my interest, as I said, guinea worm and polio, and I wrote this paper a while back, got it published last year, and it really compares and contrasts the eradication approaches for those two diseases, because they're they're both at the end game. They're very close to being gone from the world, but the approaches could hardly be more different. So firstly, to polio, those grey shaded countries are where polio was circulating in 1988, when the polio eradication initiative really kicked off. And the countries in orange, it's the same in 2016, are the countries that are the only remaining countries where polio exists as wild poliovirus now. So it's been an extremely successful program, and it's really based solely on immunisation coverage. Underlying that, obviously, a whole bunch of other factors, but the eradication strategy for polio is essentially one of very high immunisation coverage to rid it from all of its reservoirs. So, that sounds feasible, but in some places with poor sanitation, overcrowding and high birth rates, they've needed over 95% coverage. That's a real challenge. India did it. So in some of the places in northern India where there was terrible sanitation, there were some kids who needed more than 10 doses of OPV, oral polio vaccine, in order to be properly immune. So the challenge to get 95% coverage multiple times was really substantial. But if India can do it, they said that was a sign that anyone can do it in terms of technical challenges. It does depend on sensitive surveillance. You need to be able to find cases with acute flaccid paralysis, so a flaccid limb, as a hallmark of polio. And then you look at those cases with acute flaccid paralysis, or AFP, and test them to see if they've got the polio virus, so that you can see where it still exists in the world. So polio is one of those diseases that shows itself in terms of a clinical presentation, but it is tricky in as much as only 1 in 200 up to 1 in 1,000 individuals with polio will actually get clinical disease. The rest of them have subclinical or asymptomatic carriage, and yet can still pass it on to others. So you need to be looking really hard for those clinical cases of polio, because that one case will represent 200, 500, 1,000 other infected individuals in the region. The logistic requirements for immunisation globally have been enormous. It costs about $1 billion a year with the eradication campaign as it stands, and that's required really significant mapping down to house level. The security requirements, financial, as I've said, and the political will, having champions in the country at a regional and at a local level. There have been lots of arguments around whether the global eradication strategy is the right one for polio, whether it's indeed possible, and whether the $1 billion investment each year has been worthwhile, because some have argued that routine immunisation services have suffered as all the giant national immunisation campaigns have kicked off annually or multiple times a year in Afghanistan and Pakistan, while the routine immunisations on the national schedules have suffered in terms of general coverage. But I think it's a case of, if they get there, no one will complain, and if they don't, everyone will complain. So hopefully 2016 is the last year we see it. emergency operations centres, which were a feature in Nigeria when it successfully became the last African country with endemic polio. And they're really a communication, coordination, collaboration hub that maintains a focus of energy and impetus and data analysis, good surveillance and good operational responses in terms of getting immunisation teams out there and covering everyone. It used to be on coverage, numbers of children who were vaccinated. Pakistan's gone through a real strategic shift in the last 12 months where they've really looked at children who've been missed multiple times over. And so they're much more a focus on not the overall numbers, but making sure that the missed children are minimised as much as humanly possible. So this is the last few cases of polio in the world. So there's only been 11 cases this year, 6 in Pakistan and 5 in Afghanistan. So it really is the end game. And you'd think, oh, we just need to snuff out those final few spots, but the challenges are not insignificant. So you can see that there are these engines or polio hotspots that keep it going. If my cursor works up here, so Peshawar and the federally administered tribal areas, or FATA, and Khyber Pakhtunkhwa are really where all efforts need to be concentrated now, because Peshawar is considered like the conveyor belt of polio generation in Pakistan. It's exported it to other parts of Pakistan, down to Sindh and Punjab, and across to Balochistan. So getting on top of it in Peshawar will be a real key for eradication in Pakistan. Karachi, a problem for different reasons. It's got some real overpopulated slum areas, and they have trouble in much the same way that India had trouble with needing multiple doses and very marginalised populations. And then over here in Quetta, again, you'll see with these two ovals, they cross into Afghanistan. And so one of the challenges is this cross-border transmission, exporting one way and then exporting or re-importing again. So Quetta has cases that have never disappeared. Endemic transmission has continued there, but in part it's because it maintains a hotspot across the border, which you'll see here. So the counterparts to Peshawar are in Nangarhar province in Afghanistan, and the counterparts in to Quetta are in Kandahar, and they suffer, their own challenges in terms of security, insurgent activity, and what have you. India, which overcame polio, had challenges in Bihar state. So the last two regions of India that had it were Bihar and Uttar Pradesh. And Bihar spends 6 months underwater, substantial areas of Bihar underwater with the monsoonal rains every year. And so they had to come up with some very innovative ways of reaching everyone. And this is, doing cold chain with an immunisation team out to all of the little island areas that remained to reach villages right through the monsoon season. They needed to immunise monthly, and they tried to cover everyone in those two very populous, very densely populated states 12 times a year, with tens of thousands of immunisation teams, thousands of supervisors, and hundreds of district medical officers overseeing the supervisors. In FATA, it's different. This is a typical mobile team giving immunisations, and they need a security detail to go with them wherever they go to ensure their safety. In Uttar Pradesh, the challenge was sheer numbers of population as well as the sanitation issues. population 100 million, there were 120,000 new births every month. So that was 120,000 kids who'd never received a vaccine who needed to be captured on a monthly basis before they developed polio or transmitted to others. So the challenge for them was definitely trying to find everyone who was newly born and trying to reach everyone in an ever expanding population. So, you know, it's quite the exercise when you consider that Australia, you know, would struggle covering 120,000 kids every month with a vaccine that they need to get for the first time, but India succeeded. So just in summary, those challenges in Pakistan, India and Afghanistan, so that epidemiological blocks cross regions and countries. They've set up transit points where they give immunisation between Pakistan and Afghanistan, both at formal crossings as well as informal crossings where people cross over mountain passes. They've done it for hundreds of years. It's not, you know, meant to be legal, but it's always happened, always will. But they've responded by setting up transit points where they can immunise families crossing. Insecurity, as you've seen there, and accessibility. That whole region of FATA was basically Taliban controlled until about 12 months ago, when there was a big security push, and they've now been able to access children that they haven't been able to access for the 2.5 years prior to that. So FATA has seen no cases of polio this year. It's a real illustration that once you can access children, the will is there to be immunised, and you can snuff out polio. The Peshawar conveyor belt, they've got challenges of significant Afghan refugee population in Peshawar, and it's a big population. It's an overcrowded population. The floods that happened a few years back in Pakistan were a big challenge. They led to one of the biggest upsurges in polio, just as it washed through in sewage waters across the country. I talked about missed children, the fact that there were these persistently missed children, sometimes because of chronic refusal, but more often because the mapping exercises and the focus on missed children hadn't been built into the door-to-door plans for the vaccination teams. So they've gone from, you know, having a couple of 100,000 in a city as chronically missed down to 10 or 20,000. So we're seeing the results of that in Pakistan this year. There were 57 cases of polio last year, and as I said, there have been 6 to date this year. There is a technical challenge for polio, that vaccine-derived strains. So when you're using the oral polio vaccine, it can mutate and become a form that can then circulate in the environment and mutate back to a virulent form that causes polio in other kids. So Australia doesn't have that issue. We've got injectable polio vaccine, or IPV, but you know, most of the world's population still get OPV. Ironically, the solution is to have as high vaccination coverage as you can with OPV, because it really is allowed to circulate through being able to infect vulnerable children or non-immune children. But it remains something that we need to keep an eye out for in environmental detections. And then programmatic failure, lack of coordination. The emergency operations centres in Pakistan have only been in place since the beginning of this year. Prior to that, they really didn't have the focus. They didn't have the coordination. WHO were doing one thing. They weren't talking to UNICEF in the same town through the same vaccination campaigns. That has largely been overcome through these EOCs across the country. So every region of Pakistan has them, and there's a polio focal person at a ministerial level in Pakistan to keep an eye on the ball as well, and I think that's been a really key feature. So some of the ways that they've responded to these challenges, I talked about EOCs. but continuous community protected vaccination is more of that switch from annual campaigns or twice annual campaigns to, guess what, we're going to have polio vaccination available at a community level on any day that anyone is able to access it. So that's been a big shift. Just in the last month, the trivalent oral polio vaccine has been switched to bivalent oral polio. There are 3 kinds of polio virus, 1, 2 and 3, surprise, surprise. But type 2 has been eradicated already from the world, but it was in the oral polio vaccine. So the switch from trivalent to bivalent is to get rid of type 2 to stop type 2 re-emerging in the world. So, you know, 1/3 of the problem is gone. Type 3, in fact, hasn't been seen for over 12 months and may also be gone from the world. So it's really type 1 poliovirus, which is the only remaining reservoir type in existence. And we've seen the genetic variety of polio diminish as the eradication endgame has reached its final conclusions. And then, to their credit, the Global Polio Eradication Initiative said, we'll set up an independent monitoring board. That monitoring board have been brutal in their assessments and very blunt in their critiques, and I think that's been extremely useful. They've not been shy in saying where the dysfunctions were and basically holding countries and programs to account, and they publish regularly. Guinea worm, an entirely different story. Again, if you look at the map there, in 1986 across sub-Saharan Africa and India and Pakistan, but now gone from all of those countries bar 4. And even in those 4 countries, case numbers are very, very small. So this graph shows numbers from 1989, but in fact, a couple of years earlier, 3.5 million cases were counted of guinea worm. So guinea worm is an important disease because it causes enormous discomfort and poor quality of life, but it also stops people being able to engage in their normal agricultural practices of growing crops in water, and you'll see why in a minute. So we're down to 22 cases last year, and so far this year I think there have been 2. But it's very different from polio. There's no vaccine, there's no cure, there's no real effective treatment. All it's done is the worm is rolled on a stick. It comes out at about 1 millimetre a day. It's about 1 metre long, so you've got to spend weeks and weeks slowly rolling it out of the lesion that it emerges from in the skin. But unlike polio, it is easy to identify. Nothing in the world quite looks like it, and there are no asymptomatic cases. So you don't need to worry about transmission occurring to others without it manifesting itself. But essentially the challenge has been one of behaviour change. You have to drink water through pipe filters, use cloth filters when you're pouring water from your water source, and you have to isolate cases to stop them going back into a water source and spreading the worm. It's needed rewards for reporting in order to encourage people to say that they've got it so that they can be isolated and so that there can be a local response in terms of using larvicide, a bait larvicide, on their water sources to kill the worm. Here it is. It's pretty disgusting. So the female is ingested, carried on a little copepod, a little snail that sits in water, in the stomach, mates, and then migrates to some part of the body, usually a large muscle, but it can be anywhere in the body, often the lower limbs, before it emerges about 12 months later as thick spaghetti about 1 metre long. And so the break in transmission is by not having people return to the water where that worm can then reinfect copepods and sit in the water for somebody else to drink it. So the pipe filters are carried around people's necks, and if they have to drink from a puddle or from a little lake, they can use that pipe filter to drink, and the cloth filters are used for when they're getting water from a well. Wells tend to be safe, but especially from lakes or ponds. One of the unfortunate turn of events with guinea worm is that it was always known to be present in dogs, but it wasn't thought to be a reservoir until Chad, which had been free of disease for 10 years, suddenly turned up with cases, and they didn't understand why. And the answer is dogs. So dogs get exactly the same kind of guinea worm. They were eating raw fish offal from fishermen along one of the main rivers providing fish in Chad. The dogs were then getting infected. They were returning to the water, and then people who were eating those fish were getting infected. So essentially the dogs were maintaining a reservoir and a chain of transmission. So they've needed some special interventions for dogs, so tethering dogs, cleaning up fish offal after, excuse me, after fishing, and making sure that fish are cooked properly, both for human consumption and for dog consumption if they're going to be fed fish. The challenges in South Sudan are more around insecurity. So South Sudan's kind of fallen into civil war again. Lots of displaced people. Clearly there's a danger for bringing it from those few small spots in South Sudan where there still is transmission to new areas where it's reintroduced, and maybe local populations aren't so aware of it in terms of the behaviours that are required to prevent it happening. In Gambella, which is in southwest Ethiopia, the challenge is remoteness, lack of awareness, and the fact that people cross, as they have done, a bit like Pakistan and Afghanistan, cross into South Sudan. They don't really talk about themselves as Ethiopians. They move freely between those borders. So it's been a challenge again to be able to monitor the reintroduction of guinea worm into Gambella, the last stronghold of guinea worm in Ethiopia. So yeah, the dog reservoir I've talked about. There's been some lethargy in surveillance. So Ethiopia thought it had guinea worm beaten, and then it turned up in Gambella after a couple of years of 0 cases. Insecurity and inaccessibility in South Sudan in particular, cross-country transmission I've said, and just maintaining momentum in that last inch. When there were 3.5 million cases a year, everyone was concerned about guinea worm. When it's rare now to hear about a case at all anywhere in the world, it's very hard to maintain the momentum to report a case, to isolate yourself, to continue with those behaviours that are required to stop transmission, such as using cloth filters. But countries are responding by increasing the reward, trying to maintain awareness, and trying to implement some of those architectural engineering interventions that don't require that behaviour change to the same degree. So digging wells in those last 100 or so villages where that are most at risk. They've also had a name and shame, much like the Independent Monitoring Board for polio, and they've had program champions like President Carter. He kicked off the guinea worm eradication campaign in 1988, mapping and realising where the high-risk areas are, and getting local program champions and ownership of the program, especially in South Sudan, which has had the highest number of cases for years and years and years. And as I said, no cases in South Sudan this year, only 2 in Chad. All right, which brings us to an elimination target, not an eradication target. No one's really talking about hepatitis C being gone from the world for all time in all people, but there is definitely talk about elimination as a public health problem. The specific threshold for what constitutes elimination for hepatitis C hasn't really been defined, but the World Health Assembly, which is meeting this week, has got targets for global progress in hepatitis B and C, and the target for hepatitis C is an 80% reduction in incidence by 2030 compared to 2010 levels. So, there's a definite push for hepatitis C to be eliminated as a public health problem. In Australia, it's much more feasible that it is reduced even more significantly than that. So why are we concerned about it? It's a silent killer. A lot of people with asymptomatic infection go on to develop liver disease, significant liver disease. 130 to 150 million people globally infected, 500,000 dying each year. Globally, 50% are unaware of their infection. In Australia, the problem is significant. About 1% or more of the population are infected. About 75 or have been infected. About 75% of those have chronic infection. And liver cancer, and this is from Hep B and Hep C, is the most rapidly increasing cancer in Australia. So that's a measure of all the infections that occurred in Australia in the last 20, 30 years ago that are now becoming a significant burden for the health system, and obviously a significant problem for those individuals affected by Hep C. But if you're going to have an elimination program, much like polio and guinea worm, you need to understand what the transmission is, the extent of the problem, your key populations, how many you're reaching with testing and the like. And so the challenge for hepatitis C is what sampling do you do to understand how many people have it in Australia or what percentage of people have it. Random sampling, you can do simple, systematic or stratified random sampling, as I've defined there, where you might knock on every 7th door and test them for hepatitis C. But we're talking about a disease with significantly marginalised population. They're likely to underreport their illness, and they're not likely to cooperate with your routine sampling methodologies. So what non-random sampling might be considered. And why do we do it? We do it because we don't have the time and resources for true random sampling, and because we're probably not going to get those populations. They're not randomly distributed. They're not necessarily even in homes around Australia. Convenience sampling is one method. You take who you can get. You find the people you can find. And that's the cheapest option, but it's got some downsides as well. Snowball sampling is a type of convenience sampling, but it allows the participants to recruit others. And then there's respondent-driven sampling, and it uses the participants' network to continue recruitment to give estimates of the target population and the prevalence. So for Hep C, it's also true for other STIs and HIV and some other diseases. Random sampling is not appropriate, as I've said. You'd need a lot of people to test, and there's probably only 1%, as I said, of the Australian population who are regular injecting drug users. They're non-randomly distributed. They're clustered where drugs are clustered. They're less likely to be found in households. They're often in jails, or more likely in jails. As I said, they're less likely to take part in random sampling, and they're less likely to report their behaviour. So we have to use methods that try and approximate conventional sampling, but still get, as best we can, a representative unbiased sample. So I'll talk through very quickly snowball targeted, response driven and recapture sampling. Snowball, you get your initial individuals, they recruit others, they can recruit as many as they like, and so they bring their friends who fit the criteria for your sampling. By but it has so-called seed bias. The people that you initially get, if they recruit a number of their friends, then the characteristics of the sample will often reflect the very first people that you've identified. Targeted sampling requires some mapping about where subgroups might be found. You need very good mapping. It's more representative, but it's more expensive as well. Respondent-driven sampling is a kind of improvement on snowball sampling. It's based on snowball. You get your initial individuals, but the subsequent respondents and the initial seeds get limited coupons to recruit further respondents. So in multiple waves of recruitment, you don't get that bias around the first individuals you've identified, because they're limited in the number of people that they can recruit, and you get multiple waves of recruitment until you get a kind of equilibrium in the diversity of the sample, or that your sample size is big enough. And then there's capture-recapture, where you sample once, you allow everyone to return to their usual place, and then you sample again at another point in time, and based on those who you've captured again, you can make an estimate of the population size and prevalence that way. It's got good validity, but there are some downsides. You have to have an equal chance of getting caught both times or getting sampled both times, and people move around a lot if they're in marginalised populations, and you need time enough to allow them to disperse. So you've got a tension between those two things. But what we've come to know in Australia is that around 300,000 people infected, 75% chronically, 20 to 30% will develop cirrhosis in the 20 to 30 years after becoming infected. Liver cancer is a real problem. In Australia, we're lucky 85% of those infected probably know their status, but our failures are only 1 to 2% are treated each year, and more than 80% of incident cases are people who inject drugs. So we need a multi-pronged approach in addressing the primary mode of transmission of Hep C in Australia. Prevalence among people who inject drugs in Australia is around 50%, and that makes a difference from an elimination point of view, which I'll get to. Social networks, injecting networks. This has been significant work at Burnett, where I'm based, and it's been important because the usual models around transmission kind of base themselves on a homogeneous, fully connected population where anyone can transmit to anyone. But it's very clear that the injecting network of people who inject drugs will be a powerful influence on transmission. So Margaret Hellard's work followed 413 people who inject drugs between 2005 and 2010, and they developed a transmission model to simulate spread, and an empirically grounded network model to allow simulation, and ran those simulations to see how well it reflected the real world. And it showed differences with the traditional models. It showed that actually having a network of users, of injecting drug users, was somewhat protective compared to a homogenised model, because there are gateways to transmission to other subgroups in the network, and that's very different from flu transmission, for example, where anyone can give it to anyone. And the gateway nodes in particular, those individuals who sit at critical junctures in the network of injectors, played a critical role in transmission. What the modelling allowed was to test various approaches. I'm sorry for the writing here, it's not terrific, but you can treat those who've got the highest number of connections in terms of who they share injecting equipment with. You can treat those with the most uninfected neighbours first, so that you intuitively, if you clear them of the virus, they're the most likely not to be reinfected. Or you can treat those who have the least infected neighbours first. Or you can use a treat your friends strategy. So just bring along those people who are closest to you in your network. And the modelling suggests that the treat your friends approach was as good as any approach. In fact, it was one of the best performing approaches. And so that's informed how the Hep C elimination strategy is going to work, at least in Victoria and perhaps Australia, in terms of how we recruit individuals to be tested, to be treated, and so on. This is a more realistic representation of an injecting network. You can see lots of couples there, or you know, just two individuals sharing injecting equipment, and then those more complex networks. And amongst those networks, again, I'll try and get my cursor working here. You can see that, you know, an individual there or there are really critical gateway nodes. If they can be cured of hepatitis C and the rest of the network hasn't been infected, then they become really crucial in preventing transmission. So what are the 4 pillars of elimination? Harm reduction, testing, prevention in terms of vaccination, and treatment. Harm reduction we tend to think of in terms of opioid substitution therapy, but also needle and syringe programs and medically supervised injecting centres, because they all allow for some primary prevention in terms of engaging with people who inject drugs and stopping them getting Hep C in the first place. Testing, serology and PCR are the main things, but point of care testing can be a real value add for people with Hep C. There is no vaccine yet, but I'll talk about that, and I'm going to say most about treatment as prevention. Harm reduction, don't need to say too much other than from a global point of view, there's still a lot that needs to be done. There's more that needs to be done in prisons in Australia, but it has lots of other you know, positive effects beyond just hepatitis C. So it needs to be a real foundational intervention. Vaccination, we don't have a vaccine yet. The virus mutates a lot, and it's difficult in finding a marker for protection, because people produce antibodies but they get reinfected. So that's still a work in progress. But if we can get a vaccine, it can help elimination significantly. This graph shows what a vaccine might do, even with moderate efficacy. So you can see there are darker lines and lighter grey lines. The darker lines show what happens with a vaccine of 30, 60 or 90% efficacy after 15 years. So for example, if you've got a vaccine that's 90% efficacious, try and get my cursor going again, so this line, if you can vaccinate, for example, 80 susceptible individuals per 1,000 people who inject drugs, then you only need to treat a few individuals who inject drugs each year. If you've got a 60% efficacy in your vaccine and you can immunise 80 per 1,000, you still only have to treat 10 or 12, compared to, with no vaccine, compared to no vaccine, 26, 27. So vaccination, even a moderately effective, moderate coverage, makes a big difference. Testing, a point of care test might, be very significant for marginalised populations, and even though most in Australia know their status, that's not true in Egypt, where 8% of people are infected, in part due to a leishmaniasis elimination program that went horribly wrong with dirty needles. So it's very hard to identify who needs testing. So treatment. Traditional therapies were pretty poorly tolerated, not a great uptake. interferon and ribavirin in particular gave you terrible flu-like symptoms. Pegylated interferon made the regimen a little bit simpler and a bit more efficacious, but it still had pretty bad side effects. When protease inhibitors came about, efficacy increased significantly, but 2016 is the real game changer. So we've got directly acting antivirals, and the PBS has approved Sabosvir, Ledipasvir, Declatosphere, and they have 95% cure rates. Their oral treatments, only 8 to 12 weeks instead of 6 months like the old therapies. They cover most of the genotypes that we see in Australia, which are 1, 2 and 3 largely. And even for complicated illness, they've got high cure rates. So, you know, as treatment as prevention, we can eliminate Hep C, but we need to have good screening and diagnosis, links to care. We need the infrastructure to care for people with who inject drugs. They won't go to tertiary hospitals by and large. We need a nurse-led community model, and we need to make sure that there's good compliance and high cure rates. It is cost effective, however. So some modelling suggests that if you treat 40 per 1,000 people who inject drugs annually, so that's the, let's see, where's my cursor gone? This line, then you can virtually eliminate incidence. So this is prevalence dropping down, but you can reduce incidence by more than 80% by 2030. Don't worry about that. And Edinburgh, those interventions are much more powerful in Scotland. In Canada, much less powerful because of the level of prevalence of Hep C in people who inject drugs. The higher the prevalence, the harder it is to overcome transmission quickly because reinfection happens at a much higher rate. So Melbourne's kind of in the mid-range, but it's definitely well positioned. Cost effectiveness. This is a model that just shows people at different levels of fibrosis, what happens if you can treat them, and what happens at various rates of reinfection, and what do they cost to the system. These basically show that you can really significantly affect people in early or late stage of liver disease, depending who you target. But let me go to the next slide. This is the last one, I believe. So do we treat people who are in late stage liver disease because they're going to die in the next few years? Or do we treat people who inject drugs because they're the real engine of transmission and they're going to be the ones who are burdening the system 20 years hence with their late stage liver disease? This basically shows that we can do both. So top right graph, bottom right graph, treating about 5,000 IDU-acquired infections per year, Australia-wide, but also 5,000 late liver disease each year for the next 5 years. So you reach your mortality targets for WHO and for Australia by making sure people who've got late stage liver disease get cured, but you also address transmission down the track by really targeting current injectors of drugs and cutting through that injecting network. So in summary, for all those diseases, every disease is different, but you've got to understand it to be able to address it. You need the political will. You need to address those structural issues, whether it's behaviour change or the logistics of vaccination. And as a general rule, the money you spend now will save on future costs. And if you're going to be in the eradication or elimination game, I wish you the best of luck. So open to questions.
Thank you, Dr. Sutton. If anyone wants to ask or submit any questions, please just use the group chat function, which appears at the bottom of your screen. The two little chat bubbles there at the bottom. If you click on that, you can send through a question. Otherwise, for everyone who's connected in by webcast, Dr. Sutton, did you want to provide your email so they could shoot through any questions directly to you?
Sure. So it's Brett, B-R-E-T-T .Sutton, S-U-T-T-O-N, at Burnet, B-U-R-N-E-T, .edu.au.
That's great. Thank you. We'll give it a few minutes for the questions to come through.
You might all be worn down by having overcome 3 critical diseases.
Yeah, I don't think there's any questions for the moment, but they can send them through straight to you if they wish afterwards. Thank you so much for your time.
Pleasure. Thank you.